Chapter 37, Respiratory Drugs. We're going to start with the diseases of the lower respiratory tract, COPD or chronic obstructive pulmonary disease. Also asthma, which is persistent and present most of the time despite treatment. Emphysema and chronic bronchitis. There are 4 categories of asthma. We have intrinsic, occurring in patients with no history of allergies. Extrinsic, which is occurring in patients exposed to a known allergen. We have exercise-induced asthma and drug-induced asthma. Here is a chart of our 6 steps of stepwise therapy for management of asthma. This is very important that you learn and understand and know and become familiar with the different steps. This is something you will have to do a lot of patient teaching on in regards to discharge management, especially when there's been changes to asthma therapies. Status asthmaticus is prolonged asthma attack that does not respond to typical drug therapy. It may last several minutes to hours, and it is considered a medical emergency. Make sure you are aware what status asthmaticus is. Chronic bronchitis is the continuous inflammation and low-grade infection of the bronchi, excessive secretion of mucus, and certain pathologic changes in the bronchial structure. Often occurs as a result of prolonged exposure to bronchial irritants. Emphysema is air spaces do enlarge as a result of the destruction of the alveolar walls. It's caused by the effect of proteolytic enzymes released from leukocytes in response to alveolar inflammation. The surface area where gas exchange takes place is reduced. Effective respiration is impaired. Our pharmacologic overview. So we have bronchodilators. These drugs relax bronchial smooth muscle, which causes dilation of the bronchi and the bronchioles that are narrowed as a result of the disease process. You have 3 classes. You have a Beta-Adrenergic, agonist, an Anticholinergic, and a xanthine derivative. Then we have short-acting beta-agonist or a SABA inhaler. Some examples of those include albuterol or Ventolin. That's probably the most popular. You can read the other ones that are listed. Then you have your long-acting beta-agonist or the LABA inhaler. That one, I would probably say the Serevent is the most popular one that I see. You know, as far as inhalers are concerned, insurance really drives and is the predictor as to what the doctor is going to prescribe based on what the insurance will accept. SABA is used during acute phase of asthmatic attacks, quickly reduces airway constriction, and it restores normal airflow. So these are our rescue inhalers. Agonists or stimulators of the adrenergic receptors in the sympathetic nervous system. Beta-adrenergic agonist indications, relief of the bronchospasm related to asthma, bronchitis, or other pulmonary diseases. It's used in treatment and prevention of acute attacks. It's used in hypotension and shock. Contraindicated for uncontrolled hypertension, cardiac dysrhythmias, and a high risk of stroke because of the vasoconstrictive drug action. Beta-2 albuterol. Adverse effects are hypotension or hypertension, vascular headache, and tremor. Interactions, you may see diminished bronchodilation when non-selective beta blockers are used with the beta agonist bronchodilator. You also have interactions with MAOIs. Sympathomimic mimetics. You're going to monitor patients with diabetes because an increase in blood glucose levels can occur. For our long-acting, never should it be used for acute treatment. It's not going to work in an emergency situation. It should be used for the maintenance treatment of asthma and COPD, and is used in conjunction with an inhaled corticosteroid. Salmeterol should never be given more than twice daily, nor should the maximum daily dose, 1 puff twice a day, be exceeded. Acetylcholine causes bronchial constriction and narrowing of the airways. Anticholinergics bind to the acetylcholine receptors, preventing acetylcholine from binding. The result and the indications are prevention of bronchospasm associated with chronic bronchitis or emphysema. It is not to be used for the management of acute symptoms. Anticholinergic adverse effects include dry mouth or throat, nasal congestion, heart palpitations, GI distress, headache, coughing, and anxiety. For Atrovent, it is the oldest and most commonly used anticholinergic bronchodilator. It's available both as a liquid aerosol for inhalation and as a multi-dose inhaler. It's usually dosed twice a day. Xanthine derivatives, drug effects, cause bronchodilation by relaxing smooth muscle in the airways. The result is relief of bronchospasm and greater airflow into and out of the lungs. Also, it does provide CNS stimulation, cardiovascular stimulation, increased force of contraction, and increased heart rate, resulting in increased cardiac output, an increased flow of blood to the kidneys. So it also has a diuretic effect as well. Our indications include dilation of airways in asthmas, chronic bronchitis, and emphysema, mild to moderate cases of acute asthma. It's not for the management of an acute asthma attack. It can be used as an adjunct therapy, drug therapy, in the management of COPD. Should not be used as frequently because of potential for drug interactions and variables related to drug levels in the blood. Smoking does increase its excretion. Adverse effects include nausea, vomiting, anorexia, gastroesophageal reflux during sleep, sinus tachycardia, extrasystole, palpitations, ventricular dysrhythmias, transient increased urination, and hyperglycemia. Aminophylline is IV treatment of patients with status asthmaticus. Remember, this is a medical emergency, who have not responded to fast-acting beta agonists such as epinephrine. Non-bronchodilating respiratory drugs include the leukotriene receptor antagonists. Those include montelukast, that's a very popular one. Then we have corticosteroids. You may see dexamethasone, fluticasone. Those are very common drugs that we will see. Mast cell stabilizers are rarely used. Cromulin and netochromil, which are sometimes used for exercise-induced asthma. Our leukotriene receptor antagonists are non-bronchodilating. They're a newer class of asthma medications. They're currently available. Drugs include what you see listed here. Like I said, montelukast or Singulair is probably the most popular. The mechanism of action is leukotrienes are substance released when a trigger, such as a cat hair or dust, starts a series of chemical reactions in the body. They cause inflammation, bronchoconstriction, and mucus production, resulting in coughing, wheezing, and shortness of breath. The drug effects include prevention by blocking leukotrienes. They prevent smooth muscle contraction of the bronchial airways, decrease mucus secretion, prevent vascular permeability, and decrease the neutrophil and leukocyte infiltration to the lungs, preventing inflammation. Our indications are going to be prophylaxis and long-term treatment and prevention of asthma in adults and children 12 years of age or older. It's not meant for management of, once again, acute asthmatic attacks. Montelukast is also approved for treatment of allergic rhinitis. Improvement with their use is typically seen in about 1 week. Adverse effects. So with the Zolotan, headache, nausea, dizziness, insomnia, and then Zarfalukast and Montelukast, you're going to see headache, nausea, diarrhea. Corticosteroids. Anti-inflammatory properties used for chronic asthma. It does not relieve symptoms of acute asthma attacks. May be administered IV, oral or inhaled forms. Inhaled forms reduce systemic effects. May take several weeks before full effects are seen. The mechanism of action for corticosteroids are to stabilize membranes of cells that release harmful bronchoconstricting substances. These cells are called leukocytes or white blood cells. Increase responsiveness of bronchial smooth muscle to beta-adrenergic stimulation. Dual effect of both reducing inflammation and enhancing the activity of beta-agonists. Corticosteroids have also been shown to restore or increase the responsiveness of bronchial smooth muscle to beta-adrenergic receptor stimulation, which results in a more pronounced stimulation of beta-2 receptors by beta-agonist drugs such as albuterol. Inhaled corticosteroids, here is a list of them. You can see Decatron is probably an popular one. Pulmicort, Serevent, those are all very popular. Indications for inhaled corticosteroids, they are the primary treatment of bronchospastic disorders disorders to control the inflammatory responses that are believed to be the cause of these disorders. Persistent asthma, often used concurrently with beta-adrenergic agonists. Systemic corticosteroids are generally used only to treat acute exacerbations or severe asthma. IV corticosteroids, acute exacerbation of asthma or other COPD. Contraindications would be drug allergies, not intended as sole therapy for acute asthma attacks, hypersensitivity to glucocorticoids, patients whose sputum tests positive for candida organisms, and patients with systemic fungal infection. Adverse effects include pharyngeal irritation, coughing, dry mouth, oral fungal infections. Please remember that. Oral fungal infections, very important to teach patients how to rinse their mouth out after using their inhalers. Systemic effects are rare because low doses are used for inhalation therapy. Drug interactions are more likely to occur with systemic versus inhaled corticosteroids. They may increase serum glucose levels, possibly requiring adjustment in doses of anti-diabetic drugs. Remember, any kind of steroids are always going to impact a person's glucose level. You have cyclosporine and tacrolimus, phenobarbital, rifampin, those are all very common. Phosphodiesterase-4 inhibitors, including daily Resp or Flumionast is indicated to prevent coughing and excess mucus from worsening and to decrease the frequency of life-threatening COPD exacerbations. Adverse effects include nausea, diarrhea, headache, insomnia, dizziness, weight loss, and psychiatric symptoms. Monoclonal antibody, anti-asthmatic, so Xolair is what we're talking about here, selectively binds to the immunoglobulin E, which in turn limits the release of mediators of the allergic response. Xolair is given by injection, the potential for producing anaphylaxis. We have to monitor closely for hypersensitivity reactions. We need to encourage our patients to take measures that promote a generally good state of health so to prevent, relieve, or decrease symptoms of COPD. Those include avoid exposure to conditions that precipitate bronchospasm. So know your triggers. What are triggers? Allergens, smoking, stress, air pollutants. Adequate fluid intake, that is so very important. Compliance with medical treatment, and avoid excessive fatigue, heat, extremes in temperature, and caffeine. We're also going to teach our patients to take bronchodilators exactly as prescribed, ensure that patients know how to use inhalers and MDIs, and have patients demonstrate use of these devices. We're always going to teach with inhalers as the teach-back method. I think we discussed that when we talked about patient education last class. Monitor for adverse effects. You're going to also monitor for therapeutic effects. What do we expect to see? Well, we expect to see a decrease in dyspnea, a decreased wheezing, restlessness, and anxiety, improved respiratory patterns with return to normal rate and quality, improved activity tolerance, and a decrease in symptoms and increased ease of breathing. Nursing implications for xanthine derivatives. We want to be aware of drug interactions with all of the drugs listed here. Oral contraceptives, allopurinol, certain antibiotics, flu vaccine, and others. Cigarette smoking enhances xanthine metabolism. Interacting foods include charcoal broiled, high protein and low carbohydrate foods. These foods may reduce serum levels of xanthines through various metabolic mechanisms. Patient education for inhalers. For any inhaler that's prescribed, ensure that the patient is able to self-administer the medication, provide demonstration, and also require return demonstration. Ensure that the patient knows the correct time and intervals for when they'll be taking their medications, how many puffs will they be using, show them how to use a spacer if the patient has difficulty coordinating breathing with inhaler activation. Ensure that the patient knows how to keep track of the number of doses in the inhaler device.